Hi everybody, I'm Dr. Oliver. I'm one of the 2 sleep physicians at ACMC. My background, I'm boarded in psychiatric medicine as well as sleep medicine. Sleep is a passion of mine. Got interested in it in residency and took on some additional training and fellowship, and continue to do a lot of work in sleep, a lot of research in sleep, educational research, not actual experiments. And just wanted to share some of my findings with you today. I have a tendency to wander when I talk, and I would rather this be a discussion than me lecturing. So please feel free to stop me at any time with any questions. Okay. I'm supposed to talk about disclosures. I really don't have any. Just want to try to describe today some normals of sleep, some things that I see in the clinic, and kind of talk about some of the impacts of sleep problems. So where to start? Well, what's normal? Let's start there. Well, you try to define something as normal. Well, how do you define it? Well, we can talk about different things, about traits of sleep and performance markers, like how long you're sleeping, how long you're not. What are the cultural factors? What are quality factors? All these things are things that the researchers and clinicians, what we think about. I didn't know how technical we were going to get today, so some of my slides have a bunch of definitions on them. I think I'm just going to click through them. So one of the questions, for one of the prizes today was about normal sleep and age. And well, this is why I wanted to give this talk. This is what we know, or this is what we thought is normal sleep. And probably from back here you can't really see that well, so let me talk through some of this. This side we have 5-year-olds. Over here we have 85-year-olds. So lifetime sleep. And then we have all these different graphs of, okay, what the top here to the bottom of here represents is how much time a person would spend in bed based on the age. This first grade here is sleep latency. So this is how long it actually takes you to fall asleep. When you intend to fall asleep, how long does it take you to fall asleep? Let's skip over this for just a minute. What's this stage 1, stage 2, SWS stuff? When we talk about sleep, we talk about stages. And there's REM sleep, and then there's non-REM sleep. So non-REM sleep includes stage 1, 2, and slow wave sleep. So this is the amount of time a person would be in each one of these stages based on their age. And then REM. Well, what in the world is this WASO thing? That stands for how long you're awake after you first fall asleep. So, well, I thought we're all supposed to get 8 hours of sleep and sleep all through the night. Not actually true. So, if we were to do, I was told that average demographic here is about 40 years old. As best as I can do it in PowerPoint. It's close to 7 hours would be normal that a person would be sleeping all through the night. Well, what about awakenings, right? You're supposed to sleep all through the night, right? Another myth. So it wasn't until the Industrial Revolution, the invention of light bulbs, that human beings actually sleep all the way through the night. If you go to countries where there's no light bulbs, people will still have the natural first sleep and second sleep. And then there's a wake period in between. And again, this is normal. This is not abnormal. And almost a way to remember this is after you're 30, just about however many decades old you are, It's normal to have that number of conscious awakenings at night. So 40-year-olds 4, 50-year-olds 5, 60-year-olds 6. This is normal, not abnormal.
So that's why I average 5 to 5.5 hours a night of sleep. And
Could
hardly
be.
ever REM.
Could be. Let's kind of talk about this. Well, what are the stages? This is kind of what they look like. If anybody's ever had a sleep study, what they kind of look like with all those wires on your head. These are the waveforms that I look at and say, okay, well, these are delta waves. That's slow wave sleep. That wave is what I call a K complex. This little spindly thing here is what we call the spindle. And this is how we tell the difference between how you're awake and when you're asleep. One of the other questions that was up there was about dreams and dream sleep. Well, there's many theories on it, and how do you research it? Dreams originally were thought to be only involved in REM sleep. There's some evidence that people can dream in N3 sleep as well, and then the dreams are different. So N3 sleep is more of your process dreams. So if you're a watchmaker, you're making a watch in the process to make the watch. REM sleep is more your emotional and vivid types of dreams. This is the emotion that goes with giving that watch to somebody, the joy you see on their face. What about age and sex? What happens? Well, less than 55, women are here in red, men are in blue. Men, we get more light sleep. Women typically after menopause have less light sleep, less slow wave sleep, but they actually gain slow wave sleep after menopause. And all of us end up losing REM.
What does that mean? Gaining or losing slow wave sleep?
It's not part of your sleep cycle anymore. I can't, when I look at a sleep study, I can't define it as slow wave sleep anymore.
Is that good or bad? Or that-
Well, that's a great question. I mean, so one of the criteria for this is how tall this wave is. That's what I'm required to determine by the American Academy of Sleep Medicine. Now, I can look at a wave that looks exactly like that, but if it's not tall enough, I can't say that it's slow wave sleep. So is it a function of my scoring criteria, or is it a function of age? Because you go through the mechanics of it with our brain changes and whatnot, all the amplitudes are going to be smaller as we age, as to what my studies are going to be able to pick up.
What is slow wave sleep?
These waveforms, when I see these waveforms,
What am I doing when I slow wave sleep?
Deeper sleep?
that's a very interesting question to me. Is it a deep sleep? And what are you doing? So it's hard to see here. So let me go through what some of these are. These two are, if you've ever had a sleep study, I have leads right here by your eyes. Okay? This EEG is what your brain's doing. So we have 2 leads here, 2 leads here, 2 leads here. This bottom one is your chin. So you have some leads on your chin to see what the muscle tone is. If you were to eliminate my ability to see your chin in your eyes, I may not be able to tell the difference between if you're awake or if you're in REM. REM also happens more often in the second half of the night, though. So when people say deep sleep, I don't necessarily know what that means. So
Could that be when you talk in your sleep? My husband talks in his sleep sometimes, and it's usually, he's really into this rest.
Yeah, I mean, there's many different reasons why people talk in their sleep. Sometimes it's what's called somniloquy, meaning that it's just somebody talking in their sleep. What makes somebody more likely to do it? Well, if they have obstructive sleep apnea. There's something called confusional arousals, which comes out of slow wave sleep, right here typically, where you can have a conversation with somebody. And the person's not really necessarily responding normal. Won't remember the conversation in the morning. It's kind of frustrating for people that'll come in and oh my gosh, my kids, they know when to do it, you know, they'll come in an hour after I fall asleep and they'll ask me to, you know, go out and end up talking and promising things, and I wake up the next morning and here, Mom, here you are on camera, right? Pull out their cell phones. Here you are talking. Mom has no idea what happened. So there's many different reasons. One of the other things, just to come back to slow wave sleep real quick, that I wanted to point out is this is also thought to be one of the stages where our brain practices our muscle memory things. So a couple of years ago, there was at our national sleep meeting in Boston, there was an interesting study that was presented that this group of researchers took a minor league baseball team, divided the team in half while they were going through batting practices, and divided them based on their batting averages. Half the team were allowed to sleep like normal. The other half of the team, they interrupted their slow wave sleep. At the end of the 2 weeks of batting practice, the guys who had their slow wave sleep interrupted didn't have as good of batting averages as those that were allowed to sleep like normal. So some of it's muscle memory procedure process. So first big topic, insomnia. Well, this is typically what I see. You know, I'm not going to have trouble sleeping tonight. I had some milk. I read a relaxing book. I had the room temperature perfect. I have a mask for my eyes. I have my white noise maker on. I have my comfy sheets, and now I can turn off the lights and get a good night's sleep. And here comes this little ghost. Who are you? I'm the ghost of all things that could go wrong tomorrow. But I have my warm milk and comfy sheets. And ghost ends up drinking all the milk. It's going to be a long night, isn't it? Move over. I have lots of things to tell you. The fact is, our brains are most alert right before we fall asleep. The most they are alert the entire day is right before we fall asleep. Again, more technical stuff.
Now,
Different types of insomnia.
I've heard a theory that you, because your mind won't go to sleep, that it'll, if you've got a lot on your mind, that if you take a notebook with you and you write all that stuff down so you remember to think about it tomorrow, you can let it go and go to sleep. Does that work?
As long as your brain trusts that notebook. So if I were to talk about the brain like it's a person for just a minute, the brain is afraid that it's going to forget things. And everything in the brain is always thought about in present tense. So things that, happened 2 years ago are happening today, even though it happened 2 years ago. Things that are on your mind, your brain's afraid it's going to forget. So what it does, it pulls it into working memory. Goes through it a few times, sends it back to the memory banks. So what writing down does is it externalizes it. Okay, and as long as it's somewhere that you trust, Your brain's happy. What's a good example of this? How many of you have all of the phone numbers in your cell phones memorized? Anybody? Well, why not?
We trust it.
Right? Your brain has externalized this information to a place that your brain trusts. I don't have to worry about the number for my office anymore. I can just pull out my phone and I can look. I don't know what it is. Frees your brain up for other things. But if your brain can't trust that notebook, or if you never review it, that's the other key. If you never review it, your brain can't trust that things are going to be taken care of, it's not going to work. The other thing that happens is that intensity will decrease of the thoughts. And it's like a volume knob, you know, the volume from 10 to 0. It's not always 10 to 0. Sometimes it goes from 10 to 2 or 10 to 4. It helps. It's not always necessarily a cure-all. But yeah, it does help. Absolutely. Ten to 15% of adults have insomnia. As you get older, more people have it. Women are more likely to have insomnia than men. So people who have other health conditions are more likely to have insomnia. People who have worked on shifts are more likely to have insomnia. As I said, I brought lists because I didn't know. But this is just basically to say that there are a lot of conditions that have been studied that make sleep worse. There's lots of medications and medication classes that we as doctors prescribe, and there's, you know, substances that people use that do that. And the psychiatrist there's going to be some, you know, psychiatric slides in here, and it's basically in everything that I do usually has some component of sleep to it.
What about things that we may or may not normally do that would help us and hinder us? So we can make changes.
Great question. So,
You know, they used to talk about you have a glass of wine before you go to bed, and things like that. I don't know.
yeah. Okay. So that gets onto the topic of sleep hygiene. Maybe I should add that to my slide deck because I didn't bring that. You have a related one?
I think it's related.
Okay.
I was on benzodiazepines for years. I mean, that's one of the things that we do for the anxiety. But the periodic limb movement too.
Mm-hmm.
Now I see Ropinirole HCl. Is that a benzodiazepine or is it,
Mm-hmm.
so it's safe to take?
Ropinirole is a restless leg medication. It's classified by the FDA as a Parkinson's agent. As a sleep physician, I use it to treat people with restless legs. But medications have many different uses.
So that would be a better substitute rather than Transine?
Well, it depends. You know, it depends on what's going on medically. So, as far as getting back to some sleep hygiene things, really the most important thing, if there's one thing to do to fix sleep, I'm just curious, so I'm just going to give you two options. Who thinks it's more important to have a consistent bedtime? Who thinks it's better to have a more consistent wake time? Yep.
Wait, you told me that.
So if you have to pick one,
Oh.
One.
it's your wake time. Wake time every day. Helps set up your circadian rhythm
Okay.
every day. The sleep hygiene thing, you know, circadian rhythms aren't fully engaged until this more towards the second half of the night. That's what generates that second half of the night of sleep. As far as what to do before sleep, you know, it used to be thought, you know, a glass of wine. Will it help you? Sure, makes people drowsy. But a short half-life, by the time your liver's done going through it, it's about 4 hours. These studies were done in Russia with standard shots of vodka. Half hour, hour, hour and a half, 2 hours, so it's 4 hours. One standard drink before bed. Anybody who has one drink during the day will fragment their sleep, but there's a major difference between 4 hours and before your sleep versus 4 hours within. It's even worse.
So if somebody keeps a second glass by their bed. I don't drink wine, so you know it's not a problem.
What about television and electronic devices? Isn't that a big factor in using that before you try to go to sleep?
Great question. Gets into our circadian rhythms. So we have this rudimentary system in our nervous system of a blue light detector. And that blue light detector, its sole job is to say, all right, brain, it's time to be awake, it's time to be asleep. Because the truth of how your brain really works is that your brain's internal clock isn't exactly 24 hours. What resets it every day to 24 hours is that blue light sensor. In the morning with dawn light. Again, that goes back to the previous question of, you had to choose one, what would you do? Wake time, bedtime. And it's that reason. So the blue light that we get from our screens and everything else is telling our brains that it's not time to release melatonin, it's not time to go to sleep.
Okay, what if you only got 2 hours sleep? Like the night I had a sleep study, got 2 hours sleep from 6 to 8, 6 to 7:30, I think, an hour and a half sleep. Now, I got up at 7:30, but 8:30 I'm back in bed because I needed to sleep till noon to feel better. I mean, so you can't say awake time if you're like really, really tired from an hour and a half a night's sleep.
That'd be an exception. You know, there's always exceptions to things, but talking about things in general, if you're trying to fix insomnia, that's the very first thing to do. But there's also, you know, sleep debt, so that's another concept of your body needs its sleep, and if not, it's going to try to cash in. And just like any kind of credit card or loan advance place, it's more than what it's usually worth. I think this is a key concept to cover. This is a big model we talk a lot about in insomnia. We have predisposing factors before we see somebody. These are in the green, so these are anything biologically, so any kind of, you know, family history, genetics, things of this sort, psychological traits and factors. And then usually there's some sort of precipitating factor that gets you over this threshold. And this is actually a very common model in medicine. I mean, it's not just insomnia, and there's other things that we can put here. But then there's perpetuating factors that keep it going, that make it chronic versus short term. And these are usually the things that we try to address therapeutically with cognitive behavioral therapy for insomnia. That's what CBTI stands for. What stimulus control is, well, I have to control what goes on in my bed. TVs, books, readers, phones, Facebook, anything that could be animals. Yep. Sleep restriction. Well, what's that? Well, you limit your time in bed. So I'm doing these techniques, I may tell somebody, okay, I want you in bed at this time and between this time, and that's it. Because what it does is when you restrict that the next day, somebody's more sleepy, which is a good thing for somebody who has insomnia, because then it'll help reach that threshold to get them to fall asleep. And that's what I'm trying to build. Sleep hygiene, we talked a little bit about this, relaxation and cognitive therapy. And what's that? Well, if I usually start going through, I usually hear what I call the clock game. It's an alarm clock on the bedside. Oh, it's 2 a.m. Got to get up at 6. It's 4 hours. I've done 4 hours before. I feel like crap in the morning, and well, I may have to take a nap, and well, and then the thought train just goes on from there. And so, kind of going through some of those. There's others, mindfulness, hypnosis has been tried, but the American Academy of Sleep Medicine says that the highest level of evidence amongst anything, any treatment for insomnia, is cognitive behavioral therapy for insomnia. Even more so than FDA-approved medication treatments. Any one of these, the research level of evidence is low to have benefit for people.
Even the melatonin? Wow.
That seems to be the go-to for everything.
Yeah,
Yeah.
it is. Please.
For someone who is a basic non-sleeper who's in good health, no medication, is it better to go without sleep or to try to take melatonin or some of these sleeping aids on occasion? Which is healthier? I know neither are, but which would be healthier?
Making general statements without putting a full picture together is something I don't normally like doing, because I'm more of a whole picture kind of person, but this is what I'll say in general. These medications and long-term use of them in women have shown to have a higher rate of early onset dementia. They're okay for short term, but long term, this is where cognitive behavioral therapy really shines. So cognitive behavioral therapy for insomnia is as good as medicines in the short term and better long term. The questions about melatonin, these always abound. Well, there's two ways to use melatonin. One is a timing tool, and one is to make somebody sleepy. One you dose at a certain time of the day, and which is a much smaller dose to kind of give your brain a signal that it's going to be time to sleep, and then the other is a much higher dose. Melatonin's also been studied for things like we were talking about earlier, about these things called confusional arousals or sleepwalking, or people who act out their dreams. It's been studied that way. There's also other studies that, well, it's over the counter. You don't know what you're getting. There may be nothing in there. There may be lots of melatonin in there. It's actually only been 2 branded ones that are in our literature. And one, the immediate release, is only in the pediatric sleep literature. The other one was a proof of efficacy for its own brand. So there's lots of off-label treatment, but these aren't necessarily things that are used, according to the FDA. Again, not having a whole picture of somebody. This is my default. As a provider, I try to be efficient as possible. So if something can help somebody more than one way, That's what I'm gonna do. Every provider's different though. These were the two phases of sleep that I was referring to. Here's our morning sun. The Germans talked about this first. That's why the term Zeitgeber, time giver. And so we really need that morning sun. And we really don't need things like napping, caffeine, that interferes in this process, this homeostatic process. And it's because of how these align, which is why your brain is most active at night. So what about the opposite? People who sleep too much. Because that's an issue too. So this is kind of out of our chapters in our diagnostic manual. A lot of these are pretty rare conditions. So there are people who are long sleepers. Sleep is pretty much genetically determined. There are people who are okay with 4 hours. Usually they come from a family whose sleep is only 4 hours. There's other people that come from families that need 10, 12 hours. So my graduating medical school class had 120 people in it. One of my classmates, Karen needed 12 hours to sleep. If she didn't do well on tests. Karen graduated in the top 3 in her class. Sleeping 12 hours a night. The rest of us were, burning the midnight oil, right? And trying to study. Karen knew her body and what her brain needed. She slept 12 hours. There's high heritability to this and begins in early childhood, but hey, you're sleeping a lot. Well, the problem is there's actually an increased mortality to this. Insufficient sleep syndrome. This is what I see more and more and more. There's not enough hours in the day syndrome. Okay, I got to get it all done syndrome. So you're sleepy, and people have a propensity to fall asleep. Like if I'm not active and engaged in my brain, I'm going to fall asleep. And why? Well, because we've been depriving ourselves of sleep. Body and brain need it. It will cash in. Cash in at any opportunity. So people who, aren't sleeping well for 3 months, they curtail their sleep, they shut off their alarms, or they make sure other people get them up, and all right, well, I have all this stuff to do during the work week, and I'm going to sleep 4 hours, and then come the weekend, I'm going to catch up. Right? So that extension results in less sleepiness. Well, what about the nation? Well,
Results in less
it's pretty high.
sleepiness?
Yep, it resolves it.
Oh, okay,
Yeah,
so
'cause-
it's the sleep deficit, you get it back.
Yep.
Okay.
So what are some of the effects? Well, markers of inflammation, problems with the structure called the hippocampus. This is the brain center, the memory center of the brain. And brain doesn't regenerate as well. There's all sorts of things, derangements of the autonomic nervous system, so blood pressure, your blood vessels harden faster, so put you at increased risk of heart attack and strokes. Leptin and ghrelin systems, these are hunger centers and satisfaction centers. Okay, how you respond to sickness, how much you inflame as a result. About the cognition, I can go through these slides, but basically anything your brain does, mood, attention, memory, concentration, IQ. If I take somebody who has normal healthy sleep and I deprive them and I give them standardized scores, tests, and whatnot, and I sleep deprive somebody, everything gets worse. Decision making gets worse. Attention gets worse. Concentration is worse. You don't read emotional cues from people around you as well. more likely to have mood disorders and anxiety. Anything your brain does gets worse with the lack of sleep. What about this thing called the delayed sleep phase syndrome? Well, these are my night owls. Okay, your body's here in Ohio, but your brain's internal clock, your circadian rhythm's out in Hawaii. So these are my folks that will go to bed at 3 in the morning. Naturally, that's what the brain wants to do. That's where their clock is. But then, well, you got to be up at 7 o'clock in the morning for work. So it's something to distinguish out. What about psychiatry? Well, that's in there too. It's associated. People are more likely to develop mood problems, anxiety problems. I think we'll cover that. Well, what about medications and substances? Well, yeah, lots of meds that we prescribe. What about substances? Alcohol, just about any substance that can be abused can cause a problem. Even medications as a psychiatrist that I prescribe can make people more sleepy. Sometimes that's a good thing if somebody has insomnia, right? What about substances? Well, there's changes with alcohol and cocaine and cannabis and all these different things that we talked about. And again, brought data just in case you guys want to talk about data. What about medical conditions? Treat a lot of people with sleep apnea. It's not uncommon. Traumatic brain injuries.
I have sleep apnea. I can't use it though. I can't pulse. I can't stay asleep with it. That's why I'm over here dozing off now.
It's a tough thing to treat. I mean, CPAP is it's actually one of the most effective things in medicine.
Is there a way to train myself to get used to the machine, just keep at it?
Well, there's 3 parts to a machine. There's a mask, a hose, and the machine itself. Each part, like medicines, you can make changes and things are different. The most common reason why people can't use CPAP machines is because of the mask. But there's settings. I mean, some people can't keep asleep because their settings aren't right. Right? So, what's sleep apnea? It's kind of a choking disease. We'll get there, but basically your airway's collapsing. Well, if you don't have the right settings of your machine and your airway's still collapsing, well, guess what? You're going to wake back up. And so it's one of those, I can talk about things in general.
I want to go to the traumatic brain injury thing.
Sure.
What kind of effects can we expect from that? My niece was just in a bad accident.
Sure.
And,
Typically, I mean, all brains react differently, but the typical course is that people will usually have insomnia and then they get into this new term that's being introduced in sleep medicine called pleiosomnia, meaning that a person needs more sleep than what they originally needed before they had the traumatic brain injury. I mean, this happens most commonly more when they're young. I mean, the military population is huge, right? Roadside bombs, et cetera. So, actually, that internal clock starts to be affected as well, depending on what parts of the brain are affected by the trauma. So obstructive sleep apnea. Okay, well, what is it? When we talk about different things, we call apneas, meaning without breath. So on the sleep studies, we have these things that look like sensing how people are breathing. And if that airflow is not happening for at least 10 seconds, well, that's a respiratory event we call an apnea. Hypopnea is a reduction in the airflow and your oxygen levels on that pulse ox that people wear goes down by at least 4%. Differences between men and women, not in here, but men have more apneas than women. Women have more hypopneas than men. And so, what's this index? I'd like to talk about this AHI thing. So what in the world is that? So that's the number of apneas plus the number of hypopneas divided by the total sleep time of the study. And then we scale that out. So 0 to 5 is normal. 5 to 15 is mild, 15 to 30 is moderate, 30 above is severe. So, and we can make the diagnosis either way. So if somebody's above 15, they automatically have sleep apnea. Well, if you have more than 5 and you have some comorbidities right away, ever had a stroke, a heart attack, high blood pressure, AFib, diabetes, mood disorder, cognitive dysfunction, we can make the diagnosis too. There's lots of reasons as to why this happens. Again, if we can, if you want to talk about it, we can.
Would an inhaler or corticosteroid itself, I mean, if it was like allergy causing blockage?
Great question. So it gets into a bigger question. So there are differences in their medical legal as to why. So the pediatric sleep providers talk about what's called the one airway hypothesis. So if a person has allergies, they're much more likely to have asthma. They're much more likely to have sleep apnea. So allergies typically manifest themselves here in the airway, sleep apnea is here, asthma is down here. Okay. So then the implicit question is, well, does antihistamines, do they improve sleep apnea? They don't. In kids, there's a type of medicine that can help, and it's usually used as a step in between. So in sleep fellowship, I actually had to put a 3-year-old on CPAP because the first thing to do in kids is usually, if it's appropriate, to take out the tonsils, and then next is this medicine, and then third is, well, put kids on CPAP too. Because of all these reasons about how sleep affects the brain, right? So this 3-year-old now was more likely to have cognitive problems, behavioral problems in school, not developed right, but here's this young man just running around, happy kid, right? So, but I heard somebody say their AHI was 35, this kid's AHI was 50, 50. So to put it in perspective, 60 means that every minute a person's asleep, 10 out of 60 seconds they're not breathing right. So he was almost that bad, had 3. This high blood pressure, this is a screening tool. I know you mentioned screenings and sleep studies. Is this part of this? For screening? So there was an anesthesiologist that came up with this screening tool. It's called the Stop Bang, because the anesthesiologist figured out that, well, people that I intubate for surgeries that have sleep apnea, well, they're much harder to control the breathing during their surgeries and much harder to take that breathing tube out. So is there a good way to screen people for sleep apnea? And looking at evidence, there was this tool. You snore loudly, you're tired during the day. Has anybody ever seen you stop breathing? Do you have high blood pressure, or are you being treated? So that's the stop part. The bang part is, well, is your BMI more than 35? Are you older than 50? Is your neck size greater than 40 centimeters? And, well, then we automatically get a point. So if you have 3 points or more, you're at high risk for sleep apnea. It's a screening tool, not a diagnostic tool. The diagnostic tool is a sleep study. And the only way to diagnose sleep apnea is with a test. There's lots of overlap between sleep apnea and depression. Actually presented a paper on this.
Thank you.